Okay, part 2 to chapter 34. We're going to now talk a bit more about the assessment portion. In our first part of the chapter, we were really talking mostly about scene size up and a lot of how we prepare ourselves and get ourselves ready to actually do the trauma assessment. So remember, in our primary assessment, we're looking immediately for any life threats. We're going to treat and identify the life threats during the primary assessment. One really stellar point here is that trauma patients can have some gruesome injuries. They can be very distracting. We call them distracting injuries many times because they're distracting really to us. What they do is they draw our attention away from potentially other things that aren't as pretty or sexy, but yet are killing the patient. So just because they have this really nice laceration on their leg that isn't bleeding really all that much, shouldn't gear us away or tear us away from the breathing problems, the mental status changes, the low oxygen saturations. You know, if the bleeding is severe, then yes, that is something that's taken care of in the primary assessment, severe hemorrhage. But just because it's visually drawing your attention doesn't mean that it is something that's going to threaten them. So don't allow that to pull you away from doing a good primary assessment. So remember, our steps in primary assessment really are starting with mobilization of the C-spine as necessary, and opening the airway with the appropriate manual maneuvers as necessary. So this in most cases would be the modified jaw thrust. Determine their airway status, their breathing status, their circulation, and their levels of disability or level of consciousness. So their AVPU. And then, of course, taking some considerations for priority patient. So again, this is going to show us that we're manually stabilizing the patient with the potential for spinal injury. From the looks of this picture, they must have a decent airway because they're not doing a jaw thrust. So in the unresponsive patient, immediately check a carotid pulse and resuscitate as necessary. If we have a carotid pulse, then we can move on back to airway and breathing. If we have the responsive patient or the semi-responsive patient that kind of responds to our presence, then we know that, okay, there must be some sort of an airway, and we can continue to do the remaining steps. Manual stabilization of the head and neck are necessary. You have to make that decision right off the bat in order to make the decision which manual airway maneuver you're going to do. Remember, they can have forces applied really to any angle on the head and neck or back. Look for any neurologic deficit that the patient has. You know, if you're looking for the D, if you said wiggle your fingers, wiggle your toes real quick, and you were able to detect that's a pretty good quick assessment of any neurologic deficit. And then check to see if the patient is in altered mental status. Remember, altered mental status doesn't mean unresponsive. It can mean increased anxiety. It can be things like combativeness, and so on and so forth. And then place both your hands on the side of the head and hold it in a neutral inline position. We're going to assess the airway. If there's blood, vomit, or fluids in there, then clear it by deep suctioning. If we have more chunky stuff in there, we may need to use a gloved finger with a piece of gauze or something to try to sweep it out. Determine if that airway is patent, and then look, listen, and feel for breathing. If you can't open and maintain the airway using the modified jaw thrust, then default to the head tilt chin lift maneuver. It isn't the preferred method, but remember, if you can't get an airway, the rest of it doesn't really matter. So they look at it as life over limb. So try as much as you can with the modified jaw thrust. But once that airway is open, consider an adjunct. Now remember, nasal adjunct can be contraindicated in some head injuries. So you got a bloody nose, you got fluid leaking from the ears and the nose, whatnot. Probably want to avoid using a nasal airway. If they're not breathing adequate, or if they're breathing as adequate, maintain their oxygen saturation at 95% or higher with your supplemental O2. If they're not breathing adequately, then you need to ventilate them. So high flow O2. If the lung sounds are diminished or absent on one side of the chest, you can consider that they have perhaps a collapsed lung that's led to either a pneumothorax, which is air in the space, or a hemothorax, which is blood in the pleural space. Assess their circulation. Remember, we're looking for their pulse. We're looking for some of the qualities that go along with that. Is it regular? Is it irregular? Strong? Weak? We're also going to look to see for an approximate rate. Look at their skin. Pale, cool, clammy. So what's the color? What's the temperature? What is the moisture? We're also going to look specifically for cool, clammy, diaphoretic. Pale, cool, clammy skin is a sign of shock. We're going to visually inspect the patient for any severe bleeding. Now, a little bit of bleeding is not the end of the world, but severe bleeding, spraying out or a really steady flow of it, remember, has the potential to interfere with our cardiovascular system. So control those, starting with your direct pressures. And if it's hard to control with direct pressure and immobilization, then you may want to consider moving on to a tourniquet. Disability, assess their level of unresponsiveness, AVPU, and then we can use the GCS to help clarify this a little more. We can find out more about their orientation, basically through using the GCS. So remember GCS, it's you can get no worse than 3, no better than 15. Your eye opening is simply AVPU, 4, 3, 2, 1, alert, verbal, painful, unresponsive. The verbal response, if they're oriented and responding appropriately, 5. If they're confused but responding, 4. If they are responding but the words are completely inappropriate to the conversation, it's 3. If the words are incomprehensible and they're just kind of mumbling and grumbling, it's 2. No response is a 1. And then obeys command. For motor response, obeys command is a 6. They localize pain, where they try to swat away, basically, is a 5, or can tell you what they're doing, what you're doing. Withdrawing from pain or rolling out of it is a 4. Abnormal flexion, you give them a little painful stimulus and they flex their arms up towards their chin, curl their chin in. That's decorticate posturing is a 3. Decerebrate posturing or extension, where you give them that noxious stimulus and they stretch their arms way out and flex, hyperextend their neck, is a 2, and no motor response is a 1. The primary assessment, expose your critical trauma patients. If they're critical trauma patients, they're unresponsive, they can't give you everything that you need for verbal communication, make them naked. Okay? Even if they can and they have a high index of suspicion, then make them naked anyway. Protect their modesty, keep them warm. So sheets and blankets. It might be a good idea for your service to talk to the hospital and say, can we get a supply of hospital gowns that when we cut a patient's clothes off, we can cover them with the gown. Most of them have snaps and whatnot, so if we have to go around an IV. The rapid trauma assessment for your critical patients and those for a significant MOI. These are the people we need to get on the road. We have a goal of no more than 10-minute on-scene time. So call that the platinum 10 minutes. Baseline vital signs, a quick medical history. Medical history might be something you're getting on the way to the hospital. And then either a focused or a complete head-to-toe exam, depending on their MOI, their complaints, their overall conditions, the number of hands you have, what all needs to be done. So in your rapid trauma exam, remember this is just a quick visualization and palpation of the vital areas of the body. So we're going to hit each one of the systems. We're going to just kind of run our hands down their body looking for anything quickly that jumps off the page at us. We can go back later to do the detailed exam when we do an inch-by-inch evaluation. But we're just doing a quick look, a quick feel, make sure nothing is jumping off the page at us. DCAP-BTLS, remember that's deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. So we check all of these areas: the head, the neck, the chest, abdomen, the pelvis, the posterior, or the back, of course, and the extremities. Baseline vital signs to include at least respiratory, pulse, and blood pressure. I hate that they put in their rate because it's more than the rate, right? It's the regularity, it's the quality, it's the depth. Temperature is a good idea as well. Subsequent vital signs, you compare those to your initial vital signs to identify trends. Whenever possible, remember, first blood pressure should be auscultated. Don't take all your vital signs as palpated. The first blood pressure should be auscultated. Then in the future, if the palpated blood pressures are close, we know we're pretty right on. We're steady. And obtain the patient's history. So don't forget sample. Signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up. So some other people to consider critical trauma patients. As if the mechanism alone didn't make us think, maybe we need to go to a high-level trauma center with this. These are some things that should make us consider. Glasgow Coma Scale less than 14. Okay, it's common for people to be a little confused, so 14 is actually pretty acceptable. Systolic blood pressure less than 90, respiratory outside of the 12 to 29 range, or less than 20 in an infant under the age of 1. Then our goal is going to be to treat, package, and begin transport. We'll do the rest on the way. Our focused trauma exam is going to isolate on injuries without significant MOIs. We get called to the ballpark, somebody slid into base, their foot caught, and now they're complaining of right ankle pain. Do we really need to do an inch-by-inch head-to-toe on this person? No. Do we still need vital signs? Yes, because that tells us some critical information. But do we really need to see if they have periorbital ecchymosis? We'll probably know that. We can probably see if they have Kuhn's eyes, but the chances are pretty slim. The patient's completely alert, they're oriented, they're telling us, hey, I slid into base, the story all makes sense, everybody else around saying, yep, that's what happened. We really probably don't need to go that far. Now, if we have time, of course, we'll do a head-to-toe. We'll do the complete detailed assessment. So this is just kind of a quick reminder of how that whole thing works. So we start with the head, run our fingers through the scalp, looking for blood on our gloves, feeling for anything that's out of place. Feel the orbits, palpate the face, the forehead, the jaw, the nose. Look in the eyes, check the pupils, look in the mouth, look for any drainage, any cerebrospinal fluid. We're going to look at the nose, look for any flaring in the nostrils, look for damaged teeth, look behind the ears for paddle signs, observe for JVD, palpate the trachea to make sure it's midline. Preferably we did this before we applied the collar because we've now hidden the jugular veins and we can't assess that once the collar is on. And then just run your fingers down the side to make sure it's in proper alignment. Look for any retractions. Very, very slightly and gently stress the chest a little bit, looking for any crepitus or subacute emphysema. Listen for lung sounds. Observe for any paradoxical movement. Palpate each quadrant of the abdomen. Start furthest away from the painful parts. Observe the patient to see if they grimace. Trying to determine if their stomach is, if they're guarding or if they have a firm belly, a tender belly, so on and so forth. Check the pelvis. Very gently press downward and outward, and then very gently push inward. We're just simply looking for any reaction. So we're not trying to truly stress that pelvis. If they have a pelvic injury, just the very slightest pressure in one way or the other will elicit a response. We'll be able to determine, hey, there's a fracture, because it is painful. Too much pressure, too much stress on it actually can cause clots to burst, clots to break, and cause them to hemorrhage. So observe for signs of wetness. Observe, which could be blood or urine. Look for priapism. Palpate each leg, going down, down, down. Have them push and pull against the resistance of your hands. Each arm. Have them squeeze your fingers simultaneously to check motor function. Check peripheral distal pulses. Check cap refill. Palpate as much of the back as you can with both hands. Feel for any soft spots, any crepitus. Preferably, we did a nice formal, detailed evaluation of their back before we rolled them onto this backboard, because once we put them on the backboard, we no longer have that easily accessible for us. Okay, grip test, foot flexion test. Okay. Again, reassessment includes reassessment at 5 and 15-minute intervals depending on their stability. Transport to the most appropriate facility. And the mode of transport, you're going to have to make a judgment call based off of your local protocols, as which is more appropriate, ground versus air. So air transport depends a lot on various issues such as the patient's condition. Cardiac arrest is not appropriate to fly a cardiac arrest patient. Okay, there is no room in a helicopter to do all that crap, and for the probability of survival, the risk outweighs the benefit. Estimated time of arrival of the aircraft. If you have the patient out and packaged, you should not be sitting still with a trauma patient. You should be on the road. If nothing else, work out something with the helicopter service that says, okay, we're going to meet you halfway. Weather conditions, remember, helicopter has very limited weather conditions that it can fly in. What is the ground transport time and the location and potential landing zones? If you have good terrain that you can easily set down a helicopter, and you're going to have to load a patient up and transport them halfway there anyway, you're going to have to consider those things. And then consider specialty care hospitals provide specific services such as a trauma center or a burn center. Okay, scene of critical trauma patient is very hectic. You've got to remain focused and organized, do a systematic assessment. I can't emphasize that enough. So many times we see advanced level students trying to hop around on their assessment, particularly when they're getting tested. It's a system. Go the same way every time. You don't leave things out. Treatment, packaging, and transport decisions. Failure to manage an emergency in an efficient manner can lead to morbidity and death. And our goal, minimize scene time, begin transporting patient to the nearest appropriate medical facility as soon as possible.